Hospital. This is Glasgow on a balmy summer evening. As I mentioned earlier on, it's 18 degrees here, so everybody's out dancing in the streets in Glasgow because the weather's so amazing, but it's usually raining. This is the outline of my talk. I'm going to talk about OPAT, why, who, and when, how we do it, what the outcomes are like, why it makes economic sense, and a bit about OPAT education. It's going to be very much a UK perspective, so I'll apologise for that. And a lot of the focus will be on the British Society of Antimicrobial Chemotherapy OPAT initiative, plus a lot of my own personal views. And there's some data that I'll be showing which hasn't really been seen before. And where you see this little mark, I'd be grateful if you don't share those specific slides. So although I think the title is about what South Africa might be able to learn from our experience, I am not presupposing that I can tell you what to do. I'm just going to let you know what we do, and I think it would be good if you can look at it and see if there's anything that might be possible for you to sort of select from the kind of palette of opportunities I think that OPAT can give you. So we've had a national OPAT program or a national OPAT initiative through BSAC for now. I haven't got a fancy infographic for 13, but this was produced for our 10-year anniversary. But we're now at 13 years of some national coordination UK-wide of OPAT. And there have been lots of initiatives which I'm going to touch on as we go through the presentation. So OPAT isn't new. It's been around since the late 1970s. It's been in pockets of the UK, practiced by enthusiasts like myself since the early 1990s. What it is essentially is delivering an IV antimicrobial, usually an antibiotic, without an overnight hospital stay. And this is all about utilizing your inpatient resources in the best way you can. So it's about selecting patients who do not need to come into hospital and can be managed as outpatients. And it's also about pulling patients out of the hospital that they don't need to stay in. And this has become increasingly important, particularly with COVID-19 and other healthcare associated infection threats. But it's about improving efficiency and delivering care closer to, or indeed at home. And the models of care we have are very variable, as you're going to see. It's delivery in an OPAT clinic or teaching patients to self-administer. And you can see a lady here with an infected metalwork within a humeral shaft, learning how to self-administer antibiotics. Sometimes it's nurse administration at home, but that's pretty expensive. It can be delivered through a kind of an acute ambulatory care setting as part of your general medical service. And also can be delivered in a much broader hospital in the home kind of setting. And this is the kind of model that they have, you'll be aware of, in Australia and parts of the United States, North America. But what I really want to emphasize is it's not just a facility to plug people full of IV antibiotics. So it's not an infusion service. It's an infection specialist run service. And a lot of what I'm going to say today is about stewardship and governance of OPAT and really emphasizing the importance of good practice. You may well have something similar to this in Australia. In South Africa, we have something called Realistic Medicine, which is a Scottish government-driven initiative about the person receiving care being at the center of decision-making and about personalized individual care. It's about reducing harm, waste, and variation in practice. So we've been driving home this realistic medicine as part of stewardship in general, but I think that OPAT sits very well as far as trying to aspire to individualizing patient care. There are similar kind of initiatives in other parts of the UK, and Canada has quite a program related to this. And I would hope that much of what we try and do in the UK initiative and through the Scottish Antimicrobial Prescribing Group is about ensuring that OPAT sits firmly within an antimicrobial stewardship framework. And I don't need to speak to colleagues on the call today about stewardship, but just suffice to say this systematic approach for safe and effective use of antibiotics to optimize outcome in the individual, whilst at the same time minimizing harm and preserving future therapy. So I hope that we, in a well-run, well-governed OPAT service, will be taking care of the antibiotics as well as taking care of our patients. So what kind of conditions are amenable to OPAT? Well, the short answer to that is anything that requires parenteral antibiotic therapy. The top conditions are really traditionally cellulitis, bone and joint diabetic foot infections, so typical gram-positive infections. Increasingly, OPAT services are involved in endovascular infections, including infected grafts, endocarditis, and gram-negative infections, including bronchiectasis, intra-abdominal pelvic UTI, and central nervous system and ENT, like malignant otitis externa due to Pseudomonas, which is a common kind of global ENT problem. Microbiology-wise, we try and steer away from treating just the very sensitive organisms through OPAT unless the site of the infection dictates parenteral therapy. But certainly there is an increasing focus on management of multi-drug resistant organisms where there are no oral therapy, both gram-positive, gram-negative, and also, which I think is, I'm sure you're already doing this, but mycobacterial infections. For us, more typically, avium intracellulare, but also some MDR-TB. But we're, third division as far as that's concerned in Glasgow in the UK. And then some fungal infections, and you'll see from the slide I'm about to show you that invasive fungal infections form a very small part of our workload, but to be honest, that's a small part of our workload that is in fact gradually increasing. So essentially, you can look at that, and anything that challenges you or challenges your work in patients, and as long as you're valuing the use of a hospital bed, any kind of infection that requires parenteral therapy potentially can be amenable to management through a well-organized OPAT service. This is a kind of snapshot of 5 years worth of national outcome data from our BSAC. Let's put my pointer on. Right at the end here, the biggest column is skin and soft tissue infections, and this amounts in this red line to the most number of days. So you can see more than 7,000 patients and about 45,000 bed days avoided by managing these. But then there's all these other things, which are bone and joint infections, which lead to long lengths of stay, often diabetic foot infections. And I've told you this, really anything. You can see fungal infections are there somewhere, but relatively small numbers overall. Now, the OPAT landscape is, of course, changing. And one of the important things about OPAT is you don't just set it up and you run it based on your experience from 25 years ago. You have to evolve with the changing landscape and respond to changing evidence. And I'm going to touch on that as we go through. But OPAT, in fact, sort of mirrors the hospital population and also needs to respond to hospital priorities. So organizationally in our hospitals in the UK, we have pressures on staffing, continuity of care, much more specialization, drives for much shorter stay and pressure to discharge patients, less interventions, surgical interventions, and much poorer source control than we all remember from years ago. So much more reluctance to rely on radiological drainage and not draining pus and exchanging infected prostheses and things. So these are things that really challenge us, because we know that just substituting what is best practice for IV antibiotics is not good practice. Our patient population in the UK is changing, older age, more comorbidity, polypharmacy. These are huge issues in the UK population. Diabetes accounts for about 40% of our patient population. Many of them are comorbid with heart disease, hypertension, etc. multi-drug resistant infections, gram-negative infections, definitely becoming the more challenging infections and the ones that are preoccupying more of our time. And then just the last, which I'm not going to talk much about, but the last point is that increasingly we're dealing with incurable infections, often at the end of life. And this is sort of developing into a kind of palliative OPAT model where after shared decision making and discussions of treatment goals, we are looking at sometimes prolonging people's lives as long as we can maintain quality of life, sometimes through outpatient IV infusions. So some key themes, really, some key observations are that we're challenged by earlier and less well-planned referrals, and I think that's a common theme from around the UK, much greater complexity in our patients, and I don't really need to tell you that we've been significantly challenged by COVID-19, and I'll do one slide on that later on.
Yeah.
And I'm going to keep on coming back to this issue of stewardship, because we don't want to create a monster in OPAT. And this has always troubled me, that we create something and we just plug people into it and we give them infusions endlessly when we could be giving them oral antibiotics or stopping. And this photograph I took here is a photograph of the large sort of 40-liter box we have just full of empty IV antibiotic vials. And this, keeps on reminding me that we absolutely don't want to promote IV antibiotic culture. We don't want to be complicit with our referrals. I spent half an hour speaking to a neurosurgical colleague yesterday explaining why we use more oral therapy with spinal infections now. We don't want to make ourselves too easy to access, and we don't want to encourage lack of source control. And we definitely we have to be mindful of over prolonging treatment. So that's just putting the flag up for all of you there, as well as a flag for myself. And with this in mind, OPAT really needs to operate with a good practice framework. And this has, I think, been the most important part of the BSAC OPAT initiative is really, and this has been led by my colleague Anne Chapman, who's another infectious disease physician in Scotland. She's led this and really done. We've now done two big, extensive reviews of the literature, looking at the key parts of service delivery. That's the team, the structure of the team, how we select patients, the antibiotics we should use and how we deliver them, the patient monitoring, and then really important, outcome monitoring and clinical governance. And the reference I've given you there is our latest publication, which was published in JAC AMR. I think just last year, the beginning of last year or end of 2019. So I'd encourage you to look at that. And I'm gonna kind of keep on coming back to these good practice recommendations as we come. And again, at the core of these good practice recommendations, we have antibiotic stewardship, and importantly, we have teamwork. And this is these are really the two key things, is working in a team, respecting and valuing the roles of our nursing colleagues and our clinical pharmacy colleagues, and all working together to ensure that stewardship is upheld within this OPAT practice. So in the UK, we really defined the sort of the core OPAT team as a medical infection specialist, and a clinical nurse specialist and an antimicrobial pharmacist. We do still have some OPAT services that manage to exist without an antimicrobial pharmacist, and we're continually having severe words with these teams to say that they really should not be. It's really not good practice to operate these kind of services without proper involvement of a pharmacist. And in fact, some of our OPAT services around the UK are led by antimicrobial pharmacists who are able to prescribe, who are able to do lots of clinical decision making. And some can be also led by clinical nurse consultant specialists. As well as the team, the heart of our kind of team approach, we have a team multidisciplinary meeting. This is before we all had to wear masks and remain remote from each other. This is the meeting that I had yesterday morning, where we all interact virtually. In fact, kind of Teams meetings that we have now really make our meetings a lot quicker and a lot more decisive and actually help decision making. But yeah, we've moved entirely to virtual meetings between the team for our weekly MDT. Now in Glasgow, in our typical week in our OPAT service, we discuss 50 patients. So we discuss 50 patients in about 2 hours, and this is to check all those, or 40 to 50 patients, that's to check all those patients to decide, should they continue IV antibiotics, should they switch, should they stop, have we reviewed the radiology, have we checked all the toxicity monitoring, etc. Have we liaised with the referring specialist, and potentially when discharging with the general practitioner. So when we're talking about a team, it's about having a portfolio of competencies, and it's about communication skills. And we have, as I'm going to come to, we have nurse-led, very much nurse-led aspects of a service, as well as having pharmacy-led aspects of our service. But the key thing is we're all communicating and we're all driving the service together. So I've mentioned critical role of the antimicrobial pharmacist. Stewardship within OPAT is critical. We've got increasing focus on short-term IV treatment and avoiding admission, and also linking in with ambulatory care, increasingly complex multi-drug resistant infections. So stewardship is really, really important. And the nursing role in antibiotic stewardship is also developing apace in the UK. And within our own service, we've got nurse-led IV to oral switch. They're doing a lot of the toxicity monitoring. They're acting as nurse educators for the teams that they visit on the wards. And also many of our nurses, or some of our nurses, are independent prescribers. So really important stewardship role for nurses. Don't worry about this. This is something I'm working on. So I thought I'd just show it to you. So this is a kind of model of the pathway through which patients are referred from general practice clinics to emergency departments to inpatients, and then about how we vet patients. We do all our vetting or most of it virtually through an electronic referral. We decide if an antibiotic's been indicated. The first big question we ask is whether they can go on to oral therapy and whether that needs to be supervised within our service in a so-called COPAT, or complex outpatient antibiotic therapy model. If they're unsuitable for oral therapy, then are there barriers to delivering OPAT in a traditional way, such as IV drug use? People inject drugs, and we see lots of people like that. And then we have different models for managing those kind of patients who wouldn't fit into our normal model. And then we think about patient factors, facilities, and resource, and that will decide on the model of OPAT that we deliver, and then whether it's an infusion or a bolus device that we use. So this is actually a bit of a national kind of picture that we're trying to work on and develop to further drive on OPAT within Scotland. So that initial kind of assessment of the OPAT referral, I like to call it gatekeeping. And I think your OPAT service is doing really, really badly if everybody that's referred to you is taken on and you just do whatever the referrer wants you to do. So we have to challenge the referrals. We have to say, no, that patient's either doesn't need to be on antibiotics, they can be on oral antibiotics, or we can manage them in a different way, or have you thought about this? So this vetting and gatekeeping is super important. And I've just sort of chosen 4 kind of, publicly presented or published experiences from Belfast, 2 big OPAT services in London, and ourselves. And you can see we're all kind of not rejecting, but I wouldn't say rejecting, but we're offering alternative plans in 60% of the patients that are referred to us for OPAT. So without that gatekeeping, I think you would be doing your patient and also your service a disservice. So that's very, very important. And I'll refer you back to that rather complex algorithm that we're developing. So logistics and patient factors are important when we're designing the who's coming on and how we're going to manage them. We get quite a lot of SLU in Scotland. We have quite a lot of people that live quite remotely. We've managed many people on small Scottish islands. So transport and geography are important. What kind of home support, what kind of linkage we can do with general practitioners. Are they going to administer themselves, or is the nurse going to do it? What kind of antibiotic are we going to use? Adherence with therapy is very important. And then, of course, we need a sort of 24-hour facility. And that doesn't mean keeping your OPAT service open for 24 hours, but you need contingency for what happens if something goes wrong. So that's patient education, and rehearsal of scenarios is very important when we take new patients on. So I've mentioned gatekeeping. I'm going to move on a bit more to talk about the choice of agents, IV to oral switch, a little bit about duration of therapy, and also alignment with local and national strategy. So we have quite a strong stewardship program in general in Scotland, and a lot of the antibiotics that we use in OPAT are often done to facilitate ease of administration. And so that brings us into a slight bit of conflict with the with our national strategy to use more WHO access antibiotics, less IV antibiotics and things. But it's important that your OPAT service engages with your broader stewardship, and it should be synergistic. So first of all, choice of antibiotics. You're already getting the message that this is a compromise. Ideally, we want to give narrow spectrum antibiotics and that targets suspected organism, and it's low risk for C. difficile and AMR. And C. difficile is a massive problem, or has been historically a massive problem in the UK. I don't know what the situation is like in South Africa, but it was a big problem, and a lot of our restrictions of cephalosporins and quinolones has been driven primarily by Clostridium difficile in hospitals. So we now have very low rates, and we use no cephalosporins and very few quinolones in our Scottish hospitals or primary care. The other compromise is easy reconstitution administration. We have to have reliable infusion stability, and I'll say more about the OPAT, BSAC OPAT stability program in a moment. Ideally once daily to secure good ease for patient administration, and low toxicity and predictable side effects. So these are the antibiotics generally that we tend to use, and the indications. So SSTIs, skin and soft tissue, bone and joint, diabetic foot, ceftriaxone for central nervous systems, less for Staph aureus bacteremia now, but you can see these are the sort of typical antibiotics we use. You might be interested to know we use a fair bit of amikacin for facilitating management of multi-drug resistant TB, sometimes multi-drug resistant UTIs, and also other resistant mycobacterial infections. Dalbavancin, we've fairly recently licensed drug. It's a long-acting lipoglycopeptide modeled on teicoplanin. I don't know if it's got regulatory approval in South Africa, but essentially we use this if we can't get somebody who's able to comply with usual OPAT practice and they've got a sensitive organism. So it's either a single dose for 1,500 milligrams, which is the equivalent of 2 weeks treatment, or 1,500 milligrams with a 1 week interval, which gives it an equivalent of 4 to 6 weeks. So you can see that if you're looking at saving bed days, this is a very effective way. If you're looking at reducing attendance at hospital, this is a very useful drug. It's very well tolerated, but it's really, 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 really expensive. So there's a balance there. So we try not to use it too much because it's expensive, but we do use it for patients in whom we can't ambulate for any other without any other drug. So we tend to use it for people who inject drugs. People who are frail or debilitated will not be able to attend, on a daily basis, or we can't get out to on a daily basis. We use it for some Staph aureus bacteremias, and we sometimes use it for completion of some complex infections like endocarditis, just to get them out of hospital for the last couple of weeks. And there've not been any comparative studies, as far as I know, against oral treatment. And again, we probably use way more oral antibiotic treatment than we use dalbavancin, so we'd always be considering oral therapy first. So just a bit about the nursing role and stewardship. Here's some some typical patients with skin and soft tissue infection that we've managed through our OPAT service. We have developed in Glasgow many years ago now a specialist nurse-led skin and soft tissue OPAT service. We developed something called a patient group direction, which allows us to develop a protocol rather like this one here. And the nurses receive special training. We usually give them 6 months until we sign off their competencies. And then after that, they can make decisions on patient recognition and patient assessment, and then follow up and decision-making on IV to oral switch. The drug we use is ceftriaxone, unless there's anaphylaxis to a beta-lactam. If there's a dubious allergy, we'll still use ceftriaxone. If there's beta-lactam anaphylaxis, we use daptomycin or ticaplanin. And essentially, we've set up this patient group direction in order for to optimize IV to oral switch. So daily review by our specialist nurses. Now, we evaluated this. Now, this makes me feel pretty old, but we evaluated it, when was it? Back in 2005. And in fact, just to backtrack a bit, it's within our BSAC good practice recommendations that patients who are managed via OPAT for skin and soft tissue infection should be reviewed daily by the OPAT team, not just given a week's course of IV antibiotics without a review, because often they can switch to oral antibiotics quickly. So we do that. We review them every day. And we evaluated it back in 2005. We evaluated its pre and post intervention, so rather kind of an old-fashioned sort of study. But before we introduced our nurse-led management, everybody had to be reviewed by a doctor. Every decision for IV to oral switch had to be made by a doctor, and then we introduced this protocol, and the nurses, who became very experienced, started making all the decisions. And you can see there's no real difference between cure and improvement of patients with cellulitis or skin and soft tissue. Readmissions the same, drug reactions the same, surgical interventions the same, but huge reduction in the need for medical review. So this has made our service much smarter, much slicker. And a few years later, we did a sort of longer term look at what was happening with the duration of antibiotics, of IV antibiotics for managing this condition. And we found that progressively we were seeing shorter and shorter duration. So from when we originally set up our service, 2001, it was an average of about 6 days. And now 2000, or down to 2008, a median of 3 days. And our median, I've not repeated this study recently, but I do know from our data that our average duration of IV therapy is between 2 and 3 days, and then they're switched to 5 days of oral antibiotics. So a significant improvement in trend, and again, driven by nurse stewardship. The other important thing I wanted to mention regarding stewardship within OPAT is the OVIVA study. I'm sure many of you are familiar with this. When I heard about this study, or was invited to be part of this study, I realized that this was really going to challenge OPAT practice. So I was very, very keen to be involved. Essentially, this was a multi-center UK-wide Oxford-led study looking at oral versus intravenous antibiotics for bone and joint infections, all comers, orthopedic, spinal, diabetic foot, native joint osteomyelitis. And patients were randomized to either continue on IV therapy for 6 weeks or randomized after 1 week to oral therapy. And you'll be aware that there was, prior to the study, there was equipoise, which reflected variation in clinical practice. Over 1,000 patients were randomized. The only group really that was excluded, a couple of groups that were excluded, were people with Staph aureus bacteremia, but also patients in whom there was no oral or no IV option. The bottom line was that in all comers, success was seen in 86% in both arms of the study at 1 year. That those people that got oral therapy had a shorter hospitalization, lower cost, and less line-related complication. So the big message here was we all had to go back and look at our OPAT practice and realize that oral treatment is preferred when available. There are some important caveats for bone and joint, because remember, this has been the mainstay of OPAT practice around the world for many years, that patients with bacteremia were excluded. There was no oral agent available, they were excluded. Those with significant drug interactions or multi-drug resistant infections were probably excluded because of lack of oral options. The other thing to remember is oral beta-lactams penetrate bone poorly, so there was a relatively low use of these antibiotics, and it's really because all of the management of patients was led by infection specialists. So the point is that carefully constructed oral regimes with close monitoring, like ECGs and bloods, and other drug modification by specialists supervising treatment. So we can't hand the infected orthopedic joint back to the orthopedic surgeons and have them put them on oral flucloxacillin and not do any monitoring, because that treatment will fail. This is just a snapshot of some change in practice within our own OPAT service. So you can see we were using these are DDDs per 1,000 bed days, total DDDs. And you can see we were using quite a lot of daptomycin. That's come right down, and we're now using significantly more linezolid. But of course, linezolid requires a lot of monitoring because of toxicity. So linezolid is a drug, although it's oral, it's very much part of our outpatient monitoring service. And we penned this article, which was published in JAC, talking about the transition from OPAT to COPAT, and thinking about, after as implied by the OVIVA study, thinking about, we can't continue to exist as OPAT. We need to think about complex oral therapies and having the facility for IV therapy too. And the considerations for oral therapy are complex in bone and joint, spectrum of activity, penetration to the site of the infection, toxicity and monitoring requirements, and most importantly, I think, and most neglected by non-specialists, is drug interactions. Antibiotics, particularly quinolones, doxycycline and rifampicin and linezolid and other drugs, and combination antibiotics and rifampicin with doxy or linezolid, et cetera, et cetera, et cetera. So there are lots of complexities within drug interactions, and again, this really is a call out to all, and the importance of antimicrobial pharmacists within our services. You'll also have seen the POET study, which is oral versus IV antibiotic therapy for endocarditis, and we were lucky to have Henning Bungard speak at our last but one OPAT conference in London a couple of years ago, and really just demonstrating that now the practice in Scandinavian countries is to move very rapidly from IV therapy within 2 weeks onto oral therapy, and outcomes are the same. We're slow to adopt this. We're starting to do it a bit in the UK, but it's a really amazing article, and I'm hoping there's going to be a second article giving some more of the real life experience following this, but another condition that you really have to question whether you always need the IV antibiotics. I'm going to move on a bit now to stability studies. So another important area is giving, the difficulties or the complexities of giving drugs that have challenging PK/PD parameters, and ones that you need to basically give multiple times a day. For instance, piperacillin tazobactam or flucloxacillin. Ideally, we would like to treat a narrow you would like to treat with a Staph aureus, a methicillin-sensitive Staph aureus with a narrow spectrum antibiotic like flucloxacillin. But really, there have been no published validated stability studies. So we set up the BSAC drug stability program, which is run by my colleague now, Connor Jameson, who's a clinical pharmacist in Birmingham. And essentially, we set up a number of studies, or advocated for a number of studies, to be compliant with this UK yellow cover document, which was which was about temperature stability in body-worn devices up to 24 hours a day, up to 32 degrees. And so we don't often get above 32 degrees in the UK. But essentially, if you're going to be able to sign off a drug to be stable in a 24-hour infusion in the UK, you have to have 90% of the active drug available at the end of a 24-hour period with no toxic metabolites, and it has to be within these temperature parameters of up to 32 degrees. So BSAC set out to develop these studies with partners in various corners of the world, with a commitment to open access results. So a lot of these data are available, but are held by companies who don't share the data, or they don't publicize the data. So we wanted to make it open access. So to just, I'll not dwell on this, but essentially citrate buffered flucloxacillin has been demonstrated to be stable in 24 hours at these temperature extremes after refrigeration for up to 2 weeks, and then on a body-worn device for 24 hours. So it's possible to use that in a continuous infusion using either of the 2 elastomeric devices that we tested it in. Similarly, piperacillin tazobactam, these data have just been published as well. Again, citrate buffered, shown to be stable with no toxic metabolites. So these are 2 drugs that you can give. Now, interestingly, the next drug I'm going to show you has been widely used via 24-hour infusions. But in fact, when it was investigated by the BSAC group, we found there was really significant degradation of the drug. So we lost about 40% of the drug within 24 hours. So it's entirely not suitable for 24-hour infusion. So it's interesting that some of the manufacturers of or compounders of this drug in the community, the private companies, instantly withdrew their products from the market once the BSAC data were presented. So for meropenem, you do need to use either intermittent infusions or intermittent bolus infusions. Other studies going on, ceftazidime, the preliminary data show it's unstable when given as a 24-hour infusion. There's toxic pyridine metabolites. That's not been published yet. We're also looking at ceftolozane tazobactam, looking at the significance of PK/PD versus degradation. And those data are being, I can't share those with you at the moment, they're being prepared for publication. And then also 2 drugs I was very keen on looking at were amoxicillin, getting us more back to narrow spectrum agents, and acyclovir. Amoxicillin, particularly for those deep-seated enterococcal infections where we often need to use IV therapy or other toxic oral drugs like linezolid. And the other one is acyclovir, which causes a sort of intermittent but significant issue with keeping people in hospital for 14 or 21 days. And if we go back to our kind of monitoring with an OPAT, we think about monitoring the patient, the infection, progress, the drugs, the vascular device, the blood results, including therapeutic drug monitoring, which we now do for linezolid, amikacin, teicoplanin, gentamicin. We review the radiology, as I've said, review ECGs on those people who have drug interactions, and then we update and record the management plan electronically once a week in our virtual meeting. And all the drugs that we use have significant effects. Rash, particularly with ceftriaxone, teicoplanin, anaphylactoid reactions we see rarely, but particularly marrow suppression and fatigue is a significant issue with teik. Daptomycin, you have to warn patients if you're using it about the risk of pulmonary eosinophilia. We warn patients, we give them information about this and immediately stop it. Anybody who develops a cough or breathlessness on Dapto. And of course, muscle toxicity is the other one. Ertapenem, about 5% of our patients on ertapenem will develop central nervous system toxicity and has to be stopped, and it resolves on stopping the drug. Dalbavancin, I put a question mark querying marrow toxicity because of its relation to teicoplanin. In fact, a couple of weeks ago, I saw somebody with who developed ITP on dalbavancin, whose platelets absolutely disappeared. And then we had the problem of waiting for the dalbavancin to wash out of the system. So checking bloods before you give a second dose of dalbavancin is really important. And then Mark and I, my colleague, co-lead in the OPAT initiative, have put together a kind of checklist really for how we should operate within these MDTs in this publication here, published a few years ago. Now, I've mentioned that we do use broader spectrum antibiotics and drugs that we don't tend to use in hospitals in the UK, like cephalosporins. Obviously, we're using IV antibiotics. So we want to know about line-related infections, risk of C. diff, but all these infections seem to be low from the published data. So line-related infections are low. I'll show you some data, more data on that in a moment. There is no additional risk of patient or care administration. We did I should say David Barr, friend and colleague, did a good study on this based on our Glasgow cohort some years ago. And actually, the use of cephalosporins within OPAT is actually not related to an increased risk of C. diff, but we're always vigilant to this and we will always report on it. So there's Mark. I've just mentioned him. Mark is a consultant pharmacist based in London, Mark Gilchrist, and he's the brainchild behind the BSAC OPAT National Outcomes Registry, which has really been an amazing piece of work. So we've been collaborating on this for the last few years. We've got data now, and sadly the registry is now closed, but I'll not dwell on that. But we now have data from 57 OPAT services around the UK. We would estimate probably that that's about a quarter of all the OPAT services. We got about 5 years worth of data, nearly more than 26,000 patient episodes and nearly 500,000 patient days. And you can see that a median time of 16 days on OPAT for these patients. And this is exclusively those on IV therapy. But it was complicated, like they needed to go in for a day, or they had to switch antibiotics, or did we fail to attain the treatment? So don't worry about all the detail, but that's all in our latest update of our good practice recommendations. And the last few slides really are, I'm going to focus on the economics. And if you value an inpatient bed day, then you should pay attention to this. If a bed day has no value, then this piece of work will have no value for you. So if it's valuable for you to create space in your hospitals to manage more patients, then this is important. If you have hospitals that can expand and take as many patients as you want, this is less relevant. But we just completed an important piece of work in collaboration with the Scottish Health Technology Group, where we looked at clinical effectiveness and health economic assessment. This was a very, very detailed health economic modeling. And I'm just going to show you two highlights, two top-line results. So if we look at a patient with cellulitis, the cost of an inpatient stay with cellulitis is about £2,500. So I don't know what that is in Rand, but £2,500 for a typical stay. If they attend OPAT daily for their treatment, it costs 631, so 25%. If we use that long-acting, and I mentioned very expensive drug, it's half the treatment cost of an inpatient episode. But the advantage for the patient may be they don't have to come back every day to be reviewed. So significant cost savings. And what I think is probably more important is it releases hospital beds to allow you to do the other more focused stuff you want to do in hospitalized patients. Similarly, bone and joint infections, again, same issue. A typical bone and joint infection costs over £8,000 for a typical inpatient episode. If they have OPAT daily, it costs 30%. If we treat half of their course with oral antibiotics modeled with using the kind of drugs that I've spoken about, using in supervised in OPAT, it costs about 21% of an inpatient stay. So big cost savings can be found, and I can share the links to that technology assessment if you're interested. So I'm finishing off now really quickly on COVID-19 and OPAT and education. And I've mentioned the importance of remote team working, remote management, and this has allowed OPAT to really flex and be a really useful resource as we're trying to minimize hospitalizations during a very, very difficult period of history. And also, to minimize patient attendance in hospital. So it's been a contingency for COVID-19 infection, and particularly in patients who are shielding and are just absolutely not wanting to come into hospital. And we've been trying really, really hard to promote the service as an essential part of COVID recovery in the UK, and I think we're starting to get getting some traction there, and importantly, making sure that it's not an expendable, a victim of COVID-19. Some OPAT services have been closed down during COVID-19 in order for their patients to be redeployed to look after patients with COVID-19. But BSAC has produced some guidance on this, and we've had discussions with the UK government, and this, in fact, I think has really resulted in some really high-level support from the UK government to promote development of aseptic services in NHS England and now NHS Scotland, to promote use of ready-to-use antimicrobials to support OPAT, particularly as part of COVID-19 recovery. And I'm honestly just about finished. So the last thing to say is Mark mentioned very kindly at the beginning, Mark Mendelson, that is, myself and Mark Gilchrist jointly have edited and produced this mini MOOC, which is a one-stop shop to help as an introduction to OPAT. And it's very much a multidisciplinary online learning module. Tells you about how to do OPAT, how it fits in with modern healthcare, roles and responsibilities. We have video clips with patients talking about their perspective, specialist nurses talking about their role, specialist antimicrobial pharmacists, and then a short video looking about patient assessment in the OPAT setting. And it is a worldwide MOOC, and I was interested to see that, people in South Africa have actually been looking at it. So I'd be interested to know who's been looking at it and what you think. And but overall, up to November 2019, we had over 2,000 learners complete the course all over the world. I don't know how many we're at now, but it runs every 6 months or so, and you can dip into it any time. So please, I'd encourage you, if you're interested, to have a look at that. So thank you. I hope I've made a good case for patient-centered care, which reduces the need for hospitalization. I hope that infection specialists among you see that this is really an infection specialist-led care, an important branch of infectious diseases. It's a good, cost-effective use of resources. It has to be properly managed, and really is the central importance of guidance and governance, and most importantly, stewardship is absolutely crucial. And I think as certainly in the UK, as we reconfigure the way our hospitals work, this OPAT is a real exemplar of how multidisciplinary approach to healthcare can work. And in this sort of third space that's not community, that's not hospital, this interface care, it has a very, very important position in the UK at least. I think it's really important that, if we're doing OPAT, we have an OPAT community, and the BSAC has been the real lever for that, and helping benchmark practice and OPAT education and practice improvement. And my final slide is to show you some pictures of all the amazing people that have helped drive the OPAT service development across the UK, and all the other acknowledgements, BSAC, my team here in Glasgow, Health Technology Group, and Liverpool University. Thanks very much.
Andrew, thank you. What a fantastic talk, and really, it's something for everybody in that, for all the different disciplines of people interested in antimicrobial stewardship and trying to optimize treatment and infection management, across different specialties involved. And so, thank you. And there are so many questions. I mean, just personally, I've got.
I've just noticed I've gone well over my time, Mark.
It's fine. Really, yeah. No, it's not a problem. So, colleagues, I know that some people will have to leave. I don't know, Andrew, if you're able to stay with us for 10 minutes or so, just 15 minutes, so we can. People can pose questions if they want, and I do appreciate, as I said, people may need to leave. at the bottom of your screen, there should be a reactions button. If you want to ask a question, please raise your hand. You'll see a raise hand button there to be able to do so, and we can put questions to Andrew. Andrew, while people are thinking about this, I mean, as I said, there's so many sort of so much of the details is fascinating, and we think about different questions. But I mean, from a South African point of view, you know, if you were to pare down this service to its nucleus, to the, you know, the sort of bottom line of what you need, and bearing in mind, as I said, there's only 37 ID specialists in the country. There are many people who are brilliant at infection management. How would you formulate your team, and what lessons has COVID perhaps given us in that potentially?
Yeah, I would focus on the big hitters, the ones. I suppose how you approach OPAT really depends on what the needs are of your hospitals. And as I said, you know, if you have a hospital that can expand and expand, and it's not a pressure of beds, then arguing for people not to be managed in hospital might become more difficult. So it's all about the setting. But certainly, if we look at from acute medicine point of view, if we look at the big hitters of conditions, we know that skin and soft tissue infections are the big, is the most populated group of patients, and that's something that can be managed, you know, overseen by probably within ambulatory care, if you have such a thing, within acute receiving units with infection specialist oversight. But I'm keen we keep it in-house within OPAT if we can, but it has to be driven by an infection specialist who knows what, you know, what the right thing to do is, and to create the framework. And then I think the other is the complex infections that really need infection specialist oversight and that really need IV therapy, like brain infections, multi-drug resistant infections. But as far as personnel, I think that core team is what you need. You need infection specialist leadership. You need an antimicrobial pharmacist. I know you've got many fantastic specialist pharmacists in South Africa, and specialist nurses. Now, you won't find a specialist nurse in OPAT yet, but that's the role that I think needs to be developed.
Fantastic.
I don't want to give my talk all over again.
No.
Yeah.
I appreciate that.
Yeah.
So I'm going to, Sipo has his hand up. I'm going to ask also that perhaps Natalie Shellac, and we're also joined by Dina van der Berg. I wonder whether they'd also like to give some reflections on this. But Sipo first off.
No, thanks, Mark, and thank you, Andrew, for a fantastic talk. I think Mark asked my question, but maybe just to just push you a bit, what would be the minimum you can do without for an OPAT service? Because I think that's our challenge, is understanding what would be the bare minimum in terms of infrastructure. If you just can comment on that, but maybe just to ask a second question is that you touched on the issue about line infections and the low rate of line infections. Are you able to tease out what has driven that? Is that just because the service offers nice specialized care and people look after lines very well? Because I think in your model you suggested that there are instances where patients can inject themselves in terms of antimicrobial.
Yeah.
So how do you achieve these low rates of line infection?
Okay, so thanks. So first of all, what's the minimum? So I can tell you where we started. I started with a new job in the year 2000 in Glasgow. I essentially wrote a business plan and got a short-term buy-in from my organization to employ a nurse. We deployed a nurse from the infectious disease ward. I explained what OPAT was and how we wanted to deliver it. We secured a room to do it in. And then because I'm interested in stewardship, I roped in an antimicrobial pharmacist to kind of just be involved with it from the start. So you need a room, a nurse, a pharmacist, and an enthusiast to drive it. And you need to spend an awful lot of time identifying patients, identifying the need, and making your case with the hospital managers. So that's the basic. That's the basic thing to start, and the patient population will depend on your need, as I said. So for us, the big wins were going to be cellulitis, because there's a lot of them, and they occupy, there's a lot of them. They occupy a short number of bed days, but they don't need to be in hospital. And then the second group that we identified were bone and joint infections, because everybody listens to the orthopedic surgeon. Collaborating with orthopedic surgeons to work out how we can help them manage their beds where they were most pressurized. And I imagine there's a lot of orthopedic trauma and metalwork infections in South Africa. I'm just guessing, I don't know, but they might be good people to link in with if you don't already. So we started small and then built with business cases. I wrote a grant proposal for the Scottish Health Directorate, and did a sort of project grants and service evaluation in order to secure more funding. And there's a lot of keep on going back and forward to managers to understand, what this is and why it's important. And I'm still doing it. I'm still doing it 21 years later. I'm still sitting on my latest business case, which I'm meeting my managers with. So starting small with key conditions. So it could be orthopedics, it could be central nervous system infections, it could be something else. I'm guessing you have some kind of facilities for multi-drug resistant TB where you're delivering IV antibiotics in a kind of OPAT type setting already, perhaps. I don't know.
Well, MDR TB therapy, obviously in South Africa, has changed markedly with the availability of new oral options. But I'm going to bring in Natalie, has her hand raised, and then perhaps Dina. And I wonder if we've been joined by Vanessa Carter, which is wonderful, our amazing e-patient advocate who's currently in the UK, and then also maybe Murfin Mpundo. Perhaps Murfin, you'd like to reflect on OPAT for Africa in general. So Natalie, and then Dina.
Thank you, yes, and thank you, Mark and Andrew, for a great presentation. It's really, it's great to see, what has been achieved, and I really wish we could almost share the same sentiments. And from where we are at the moment in pharmacists, we don't have the same experience always with IV therapy in an outpatient, and it's been largely, yes, driven by TB, especially with intramuscular injectables, but largely still in a nursing space, where the pharmacists would provide care to the patient, sending them home and medication reconciliation and making sure that they understand aseptic techniques. But it's still largely driven by nursing sisters, doing home care. And in some exceptions, some smaller exceptions, were especially in pediatric care, with cystic fibrosis and the likes, where pharmacists were more involved, because there's a larger medicine component and different medicines in terms of inhaled therapies, and maybe pharmacokinetic and dynamic monitoring if those patients went home, but none at the moment in the space where you are functioning in. And I think, first, before we could start thinking about having pharmacists moving into those spaces, we have to also look at aseptic techniques and really making sure that pharmacists are well and familiar with the administration techniques, injectable techniques, whereas vaccines has moved a lot of that, especially now with COVID, vaccines, and a really large scale up of having pharmacists ready in aseptic techniques and administering injectables. So I do think there is going to be a bigger change for pharmacy, but it's not yet where you are. But it's great to see what you are doing and really creating a vision for moving into that space. Thank you so much.
Thanks, Natalie. I think I'm just remembering I didn't answer the second question from SIPO, but and this relates to something you've said as well. But when we started, the nurses and the pharmacists that were involved had no experience of delivering IV antibiotics in the community. So we all started from that kind of ground zero point. So it's all been learned. It's all been learned over the years. The greatest value of the pharmacist is actually within oral therapies, which we're using a lot of the time now. Complex oral regimes, drug interactions, dosage adjustments with linezolid, with other interactions, and adjusting for toxicity risk and all that kind of thing. So it's all kind of learned on the job, but it's very much the role of the antimicrobial pharmacist. So we do value it, but I think we've all grown in experience and over the years. But we started at as I said, we started at this kind of level, but we're kind of, up here now. As far as training is concerned, an aseptic technique, the infusion devices that are used, and I have to say, we don't use infusion devices in Glasgow. We teach our patients to do it, or we get them to turn up. We're a kind of cheap OPAT model, but the infusion devices need to be compounded aseptically, so you need that resource. We don't actually have that resource in Glasgow, but other people do in other parts of the UK. But we're working towards that, and it needs refrigeration, and so that's an issue, obviously, for many patients, reliable refrigeration and things. But the key thing about the low line infection rates is that it's the careful tutoring of the patient and ensuring the competencies of the patient to deliver the drug, or the carer. And probably about 30 to 40% of our patients now that are on IV antibiotics are doing it themselves, or it's a carer. And obviously they're very, very motivated to do it properly. Now that becomes very problematic if leaving lines in for people who are going to homes that are maybe don't have good water supply, where there's concerns over hygiene. And when I've talked about this with other colleagues in Africa or other parts of the world, that's been a significant issue. And that's something that needs to be considered.
Yeah, no, absolutely. Dina, it looks like from your photo you're in Milan or somewhere, but I don't know where you are.
I wish I was. That's just to look forward to something. Yeah, well, thank you very much, Andrew. I mean, just from what I know about this field in South Africa, most of it actually, the only one that I'm aware of is at Discovery, where they actually have a team of nurses that do some outpatients. They are an insurance company, a medical insurance company. And of course, the incentive in the private sector is with them, and they've been trying to drive more of that, not only with antibiotics but with other types of treatment. And the reason for that is what you said, Andrew, is in the private sector, there is an oversupply of hospital beds. And so that business case gets really hard if you're hoping that they would fund it all. But I think it's an incredible business opportunity for whatever, a team to put together and to be pioneering in South Africa around. And I was just curious what the sort of low-hanging fruit is. I wanted to mention in one of our studies, our IV to oral ability to switch from IV to oral it went from 16% to 19%, which was very bad. And part of the reason is that wanting to keep people in hospital rather than put them on oral therapy and kick you out. But I think, by the way, that's an amazing stewardship opportunity still, and a cost-saving one. But I wondered if you had any others that were what you think are the low-hanging fruit for the business case.
Yeah. So first of all, I know about the OPAT's very attractive in the private sector, and I would want to be the last person in the world to promote it, as a money-making venture that people who don't need IV therapy just get it prolonged in an OPAT setting. And I totally agree with you. IV to oral switch in hospitalized patient is the number one step. OPAT is for people in whom that is not possible. You'd need to look at what I did was I modeled it all based on the data on admissions and who was occupying the beds, why they're occupying the beds, how long they're staying for, who are the key decision makers. And and the data is very strong for cellulitis and orthopedics, but I don't know what it is in South Africa. I imagine, as I said, infected metalwork following trauma is probably an issue. Skin and soft tissue infections are relatively low-hanging fruit if you can get people reliably to come back every day and get antibiotics. But you have to have that reliance that the home circumstances are going to support going home with a line in. You can, of course, put a butterfly vascular device in every day, so they don't have to go home with the device. That minimizes tampering with the device or minimizes contamination of the device. And we do that a lot for short-term patients in whom, they come from, less than perfect home environments. But yeah, I think understanding of what the pressures are in your hospitals is the key thing. So presenting a solution for your busy hospitals, rather than kind of creating something out of thin air. Understand what the data is and what the patients are and what the need is.
Fantastic. So I know we're sort of getting along on time now, but I mean, I'm keen to hear from a patient perspective. I mean, Vanessa, if you're still with us, would you like to give a perspective, or maybe you have a comment or question?
Hi, Mark, and yeah, thanks so much for a good presentation. It's the first time I've heard of this, so I'm quite keen to go and do your course just to understand exactly what it's about. And I mean, I just kind of I related to so many things, because in my case, I was in and out of hospital with MRSA infection. And one of the biggest things was me being part of, being upskilled to deal with, adherence and infection prevention, infection control within my home. I wasn't on IV antibiotics, but I hear your concerns as well, especially in the South African setting where there is the issue of sanitation, yeah. But as I say, I mean, my final outcome, I always felt, was because it wasn't, my antimicrobial resistance wasn't managed properly by a multidisciplinary team. So I think it's extremely important that this sort of program is implemented. So thank you.
Well, thanks very much. And I would say that, patient perspective is something we really, really value and have valued through all our work. And I think absolutely, whatever you do, don't make it all about the beds. Don't make it all about IV to oral switch or whatever, or stewardship. Make it about the patient, and the patient really has to be at the center of all the decision making and the planning of the service. So you have to make a kind of financial case, but also when you're putting a case together for this, having that patient voice, patient perspective, and keeping the patient at the center of your service development is really, really important. So thanks, Vanessa.
You're welcome.
Thanks very much, and we hope you're not too cold down in England, Vanessa. I think, unfortunately, our colleague Murfin has had to leave, and it would have been very interesting to get his view, because Murfin has been part of the ecumenical pharmaceutical network across Africa and REACT, and but I think he's had to step off to another call. But the really good news for South Africa is that my colleague Professor Blockman has agreed that we can have dalbavancin as freely as we would like it, as he's now flush with money from a local tender that he was awarded. So congratulations, Mark, and thank you.
We sold your car. So we sold the 3 cars that you got for that PPE thing. So I think we can probably afford 1 dose, if that's okay.
I'll get you 1.5 doses, I think.
Oh, magnificent!
If they're really nice cars.
Yeah. Brilliant.
Thank you very much. Thank you, Mark. So I think that that's probably enough. I don't see anybody else's hand up, and so I think, but I think this has been a really an amazing session, and I really want to thank Andrew for spending time with us, and hope that in a post-COVID world that we can welcome you to Cape Town and have you speak again, but maybe also entertain you a little bit more in with the proceeds for the dalbavancin tender. And thank you. And I will be in contact. Thank you to everybody who participated and who's listened. It's wonderful to have so many pharmacists and training pharmacists joining us today, and really people from, as I said, from across South Africa to listen to this important talk. And I hope that we'll send out some invitations to some of our other talks, antimicrobial stewardship talks that we've got planned this year. And again, thank you very much indeed to everybody for joining us. Most importantly, thanks to Andrew, and everybody have a good day.
Thank you very much, Mark. It's been an absolute pleasure. Thanks,
Great.
everybody.
I think we'll clap as a reaction. I think we can clap even if you've got your reactions on. Are we clapping? I think I'm clapping. Yep, lots of clapping.
That's great.
Most people who want to clap can't clap because, oh, Adrian's just doing a high five, I think. I don't know. Either he had a question or he was trying to clap. But Adrian, I'm going to clap for you. There you go. There's another clap for you. Thanks very much, Andrew. Take care.
Cheers. Thanks very much, everyone.
Bye-bye.
Bye-bye. Bye.